They realise what a lot of work this has been and what a lot of information you have to give out. And I've seen people like kind of converted just by sitting in on that interview and realising this is for real, this is serious, like we really need to get our act together here because they're going to come and look at a lot of stuff. And it's kind of effectively freaked out a few people. So in terms of looking at the charts, okay, they will look at charts. So there's a few things. You need to chart prenatal education, you need to chart rooming in, you need to chart skin to skin, and obviously you need to chart breastfeeding rates, you need to chart why, if the baby's supplemented, all this stuff. In terms of prenatal education, your charting will not save you. If they ask their moms about breastfeeding and they don't know the answers, it doesn't matter if you wrote it in the chart. The mom's 9 months pregnant and she doesn't know, so it didn't work. So they don't even look at the prenatal charts. They do look at skin to skin and rooming in, and I'm going to go into that in a minute. But the main reliance is on the mother and the clinician responses. So, Laurie was talking a lot about doctors, and there's a nice study out there that Elsa Tavares did about mothers and clinicians' perspective on breastfeeding counselling during routine preventive visits. And basically, the doctors think they say and the nurses think they say one thing, and the patients hear another. So obstetricians said that when they asked them how often they usually or always discuss breastfeeding prenatally, only 16%. The OB said that they usually or always discuss breastfeeding prenatally, but only 16% of the moms said that it had been discussed. And these were the same moms and doctors, by the way. It wasn't a different group. So then they asked the paediatricians, how often do you discuss breastfeeding at the 2-week visit? And the paediatrician said usually or always, and only 25% of moms said it was discussed. So what you think you say, or what you say, or what the patient hears, basically you may think you're talking about breastfeeding, but they're not hearing you. So it's not. Here's another data from the same study. 91% of obstetricians and 97% of paediatricians said they usually or always discuss breastfeeding and going back to work, but only 55% of the women that those doctors had seen said that they had been told about breastfeeding going back to work. So whether it was not true what the doctors said or whether the mothers had forgotten it, but obviously it wasn't communicated in an effective way. So they may hear us blah, 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 but do they actually listen to us? And the way to find out is the audit tools. I'm assuming that, I know that Chickasaw is just about to go into dissemination. I think you guys, are you already through the dissemination phase of Baby Friendly? The 4D pathway? So you start out in discovery, then development, then dissemination, and then designation. And each time you pay your money to get into the next phase and you go through the portal, you get new tools that you can access, okay? In the dissemination phase, you get the packet, which includes an audit tool on the staff training and audit tools for your moms. And these are basically questionnaires, okay? And you will be able to use these questionnaires. It's an open book test, this whole survey, because these are the same questionnaires that they're going to use when they come. So there's no excuse for anyone not to know the answers, because you know exactly what they're going to ask you. It's not a secret. So this is what you need to get if you haven't been onto the portal lately and you haven't downloaded stuff. And these are not produced in, I have to say, the most user-friendly way. There isn't one packet for everything. Each tool has a separate questionnaire that goes along with it, and you kind of have to find them. And one of the interviews, the readiness, the pre-interview on the phone, one of the hospitals I worked with, they actually had missed completely one of these audit tools, didn't even know it existed. So there's a lot of stuff on there. Get it out, and then you need to start auditing your patients. You need to be asking them every week the questions in these things, because that is the only way that you're going to be able to tell if things are really being done. And that's how Baby Friendly tests. They test by asking the patients. So you really want to do that. Some of the things, and there's a staff audit tool too. Now, as we've heard, I think earlier today, the doctors require 3 hours and the nurses require 15 hours, and they all get the same questions. And the nurses inevitably do better. And I don't honestly know if it's to do with the 15 hours or just to do with something else. But anyway, the nurses and staff usually do okay when we do the assessments, but the doctors usually do dreadfully. And they will ask, so there are staff audit tools in that packet too. You can use those to question your doctors and your nurses and get them ready. So who is Baby Friendly going to talk to? And this is really important because you don't actually have to train the entire hospital, and you may want to train more people than they require, but they only require you to train, and they're only going to, they only require you to train clinicians who see the mums and baby from when mum comes in labour to when she goes home with her baby. That's not the prenatal clinic. That's just on the unit when where the babies are born and cared for, okay? Those are the only people that you need to produce a certificate for Baby Friendly USA that you trained them. That would be all your nursing staff, and it would be the doctors who there in that period who are paid by the hospital. So some of you will have doctors that come in that are not paid by the hospital, but they come and do births. So you have a private OB group out there, and they do births at your hospital. Baby Friendly USA does not require you, cannot require you to train doctors who are not on your staff, because it's not your responsibility to do that. However, they could get questioned. So if Dr. Smith, delivers a baby once a week, and he happens to be there on the day that mother's having, that his patient is having a baby, and Baby Friendly USA is there, whether or not that doctor is part of your hospital, they could ask him the questions. So that's the kind of little bit that's a bit off. You have to train the people who you own, but it's possible they could actually ask questions of someone that you don't own. Okay, and that doesn't usually apply to nursing; it usually only applies to your doctor. So those are the people that they're going to ask these questions to. And they don't ask people who only see prenatal, so they don't ask an OB that only does OBGYN, they don't ask that woman, they don't ask the paediatrician who even only sees kids later on. So it's the people who see them in the hospital when they're having the baby. And what do they ask them? Well, they ask them if you have a breastfeeding policy. You would think people would know the answer to this question. People do not know the answer to this question. Often the doctors are afraid it's a trick question because it's such an obvious question. They'll start blathering on about skin to skin. And it's like, I just want to know if you've got an infant feeding policy in the hospital. It's got nothing to do with like, oh, we have this new policy now on skin to skin. It's like, is there an infant feeding policy? They will also ask how many hours of breastfeeding education you've had. The answer to the nurse is 15 plus 5, and the answer to the doctor is 3 hours. That's it. They don't. Yesterday, the doctor, I asked, it was very long. That was the answer. I don't want to know it was very long. I just want to know how, your definition of very long is obviously different from my definition of very long because it was actually a 3 hour. You need to make sure that they know how to answer that question. The doctors have to have had 3 hours. The nurses have to have had 15 hours. If you have IBCLCs, they do not have to do the training that IBCLCs consider to be enough, so they are a little different. And they will ask that question. They will ask them to name 4 benefits of breastfeeding. It's really sad that most people can't answer this. It's really kind of funny because they used to be able to answer it 5 years ago, and neither the moms nor the doctors or the nurses, they all struggle with it. They talk about nutrients and antibodies, and I don't know if it's because we've shifted our education to the kind of stuff that Laurie was talking about, and we've made the assumption that since it's all over the newspapers that people know it's preventive of diabetes and obesity and breast cancer in women, but maybe they're not. I tell you, people are struggling with this, so you need some specific health benefits, not, oh, it's good for bonding. Okay, that's not, they don't want that. And even if it's free, they don't want that. They want specific disease-oriented outcome questions on that. When should staff first help mom breastfeed? That's within the first hour of life. They will ask you if mom and baby are separated, and if you have a NICU, that means if they go to the NICU. If you transfer out, it means if they're transferred because they're to a higher level of care. When should mom start to express? I put this one in. I'm not going over every single question you ask your clinicians. I'm going over a few of the problem ones. They always think the answer is, oh, immediately. Because, it's always immediately, right? You can't go far wrong with immediately or more or something. It's within 6 hours. The evidence shows within 6 hours, so that's the kind of number you can teach people. How do you teach moms when to feed is one that's really commonly done wrong. So the old-fashioned people who haven't listened to anything you've told them still say every 3 hours, or every 2 hours, or every 4 hours, or within 6 hours, which is one we had recently. It was kind of odd. They must have got the pumping question modelled up. So they tend to need a number. So 8 to 12 times in 24 hours, which is what the AAP says is a really good number to teach them. Then the other people have started got the idea of cue-based feeding, so they'll say on demand every 3 hours. And I've had that answer many, many times. On demand every 3 hours. Well, you can't say that, right? And that happens frequently. I thought it was a freak the first time. It's all the time. And then they ask about pacifiers and stuff like that. I'm not going to go through all this. It's all in your audit tools. But there's one that's often badly done is how does the hospital teach formula feeding? People don't tend to know that and don't do that one well. They will ask your doctors to do positioning, latch and hand expression. You would think that they were asking them to, well, jump out of a plane. I mean, you know, sometimes if I can spot the doctors coming that are annoying me, I kind of have the breast right here on the table when they walk in and they're like, oh God, what's that? They do not like to demonstrate hand expression, and they pick these babies up by their heel, this toy baby, and I mean, it's absolutely incredible how difficult providers in particular find this. Nursing staff seem to find hand expression not all that easy too. I mean, they're kind of being taught it, but they don't remember what they've been taught. It's generally badly done. So go online and get the Jane Morton thing, and that's a really good way to show how to do it. And I just like this. This was one of the other hospitals that we went to. I mean, they'd obviously got the idea that the doctors had not been good at hand expression. So on the front of their provider baby-friendly education, they had this very nice doctor who volunteered to show that he was able to demonstrate hand expression, and that was what they stuck on the front of their book there. Moving on now to the patients, because they'll interview your patients as well as your staff. Prenatally, as we said, they don't actually interview your prenatal staff unless they're also involved in birth, but they do interview prenatal clinic patients, and they probably generally want about 10 people who are over 30 weeks pregnant. So prenatal is really badly done. You want to make sure that your education is done by technically 32. Actually, I wrote 30 and I really shouldn't have. It's 32. But I always recommend 30 because it's a very, very rare institution that has enough women over 32 weeks gestational age at the prenatal clinic to be interviewed. So if you take the education back a little bit and get it in by about 30 weeks, then you'll have a bunch of women who are educated at 30 weeks that they could interview. But they will do that, and you need to go make sure that you've got this right, because it's really not well done. Your prenatal education needs to it needs to be completed by 30, or at the very least by 32 weeks pregnancy. The baby could be born early, but that's what they require. Of course, you can reinforce in the last 8 weeks, but the basics needs to be done by 32 weeks, and they will interview people who are more than 32 weeks. And it ain't going to happen if you don't set it up. You're not going to walk into your prenatal clinic and find these people randomly. You have to set it up with your clinic. You have to either schedule appointments on those days for women who are almost at the end of their pregnancy. You could focus you will find out we'll find out a month in advance when your assessment's going to be. So you can say, okay, it's Wednesday, April the 15th, and on that date we will schedule all our prenatal patients that have, appointments due around then. All the 30-weekers on above will be on those 2 days. That's one way to do it. If you can't do that, you're going to have to get them in specially just to be interviewed. But you need to do that. It's not easy. Postpartum, they need 5 cesarean moms and 10 moms with vaginal deliveries. If you haven't got enough patients, they will do it on the phone. And again, it's difficult to reach people on the phone. Prenatal education, it's actually very short, fairly short what they ask them, but they ask them about whether they got anything about breastfeeding during their pregnancy. And usually most people can say yes to that. People don't know about skin-to-skin stuff. They might know what the term is, but they generally don't know it in depth. It's not easy. Rooming in, people often don't know nothing at all. No one's told them anything about rooming in. And then no one's ever taught them about the risks of giving formula. So I can almost predict that if you have not been doing audits of your prenatal patients, if you go out, you're going to have a big shock. They haven't been taught about the risks. They need to be taught about the risks, and they need to know it's risks, not benefits. They will ask them about risks. So look at the language on those audit tools very carefully. Anything else prenatal? It's kind of sad, that we don't teach these prenatal patients. And Laurie and I spend a lot of time. We hear all this junk from the doctors and the nurses about they don't want to know, or we taught them that, or we gave them the packet. I actually added to my mock survey, did you read the packet? And they all were like, no, didn't read the packet, actually. No, we don't want to read the packet. It's too much reading. I have a whole talk I do about prenatal, but the bottom line is, if you can do prenatal education and you're a doctor, all it takes is a few seconds to talk to them. If you're the obstetrician, and you're going to be there when the baby's born, and you say to the mom, I'm going to place the baby skin to skin on you when the baby's born, and that will keep your baby warm, and it'll keep her blood sugars up. That's pretty much all you need to say. You repeat that 3 times, I'm guaranteeing you they're not going to forget what their obstetrician told them, because that person's going to be there, and they're really, by like 30 weeks, they're really scared about how's this baby going to come out and what am I going to have to do here. And, you know, they will remember that. So you really don't need to create these complicated, long education plans. Just get them to, and the rooming in, I described how they did it in the Detroit hospital. So you need to be creative. But that's what you need to do. And then this is all the stuff that they ask you postpartum. Have they given you advice about breastfeeding? Helped you to breastfeed in the first hour of life? One thing that's quite interesting is often people will say, no, they didn't help me. And you know, actually, that they did help. And often, like, you know, really great hospitals that do a lot of help and support. So we actually worked with a couple of hospitals. They actually said, hello, I'm here to help you breastfeed every time they walked in, the nurse, because people didn't recognize. They thought it was just a part of the routine nursing care. So, you know, you can, you have those badges, I'm here to help you breastfeed, or something like that, because quite often people don't know that they've been given help. They just think it's part of the normal thing. So, hand expression is often one that gets overlooked, so there's a lot of stuff there. You can look again at the audit tools. They do ask patients if anyone talked to them about breastfeeding before the baby was born, and they ask about skin to skin. And they will also ask you if they've got separated from the baby. If the baby's transferred, they will ask moms if they've been shown to use a pump, and if they were shown within 6 hours. If the baby's put in the NICU or transferred. So you need to really figure out how you're going to get this information before the surveyors come anywhere near you. How are you going to collate these audit tools and get that information back to your staff? It's funny, we're doing a big project in Mississippi, and so I start to ask them, like, well, get your audit materials. Well, they hadn't, like, put them together. They'd be asking questions, but they hadn't, like, put it all together in one place. So then they started to send it to me every week, and like, here's our audit material for this week. I'm like, it's not for me, it's for you. You're the ones that are supposed to be reading this, not me. It's not, you know, you guys take it to your staff meetings. I don't need to know, you need to know. And that's the point. And one of the systems I devised, and I was telling them at Chickasaw a couple of days ago, we worked with one hospital where every Tuesday, because Mondays are too busy, every Tuesday lactation goes to the prenatal clinic, delivers a pile of blank audit tools. In that particular hospital, they had their intake person that was like checking moms in, do the questions with the moms on the audit tools. It's very short, the prenatal one. If there was an area that the patient didn't know anything about, they actually gave the paper to the clinician, the nurse or the doctor who was seeing them that day, and said, look, this mom hasn't heard about skin to skin. And you talked about it during the appointment, but not fill it out as if she knew, because well, the minute I see things like grunting on the form or any long medical terminology, basically I know that it was not the mother that said that. Nurses often write down there, you know, mother reported blah, blah, blah. And of course, mothers don't report this stuff. Nurses report this stuff. So, you know, make sure that they don't fill out the thing just because they've been talking to mom about it. You need it to be done separate. And then you collect it every other Tuesday. You take it back and you look at your percentages and you say, this week in our prenatal clinic, 60% of women knew about skin to skin. And then next week, hopefully 70% will know, and the pass mark's 80%. So you need to feed it back to the people that are looking at it. So as I said, with charting prenatally, it really doesn't help, but postpartum charting can make or break your assessment. So if they go and ask a mom, was your baby in skin to skin? And she said yes, and they say, how long for? And she says, half an hour. They will go and look at that mother's chart to find out what happened at 30 minutes. If you don't document skin to skin at all, you've lost. If you document that the baby was taken away at half an hour to have its bath, you've lost. So it needs to be a medical thing, and it needs to be in the chart, okay? And that is when it will save you, because it could be that the baby was taken away at 30 minutes because it was turning blue, and that's fine. We don't want them turning blue, so it's okay if the baby was moved for a medical reason, but it should be documented. And that will make the difference, whereas with prenatal, if they don't remember, then it doesn't make a difference, but with this it will. And the same for rooming in. If the baby's gone out of the room, you have to record that in the medical record. And once you've recorded that in the medical record, it needs to be for a medical reason. Even if it's recorded in the medical record and it went out for a bath, that's not going to help, because it wasn't supposed to go out for a bath. But if it's recorded in the medical record that the baby went out for a spinal, you're okay, because they're not going to have you do a spinal in the room. And circumcisions, they don't really look at. They know that circ's done outside the room, and they don't really worry about that. So it is important to get that charting in place. Yeah, I think. So in summary, the only way to really get to know if the staff is getting the message and if is to ask the staff and do those questionnaires with the staff. The only way to know if the patients are getting is ask the patients. And I would say if that's one thing you take out of this talk, you must do the audit tools and you must ask and you must track. And Carrie, I would like to ask you to come down, please, and add to what I just said. Since you had your phone assessment last week, and there's 2 hospitals at least here who are preparing to have a phone assessment. What time is it, Laurie? 3. Okay. So if Carrie has 2 minutes, and then I'm going to ask Cami, who came yesterday to Chickasaw with us, and I'm kind of been doing this so long, I'm kind of almost out of patience with these places. Occasionally. But Cami was all fresh to her, so I wanted her to just give you a little, like, her impression of something new. So why don't we do that? Thanks.
I was just sitting back there thinking, it's so nice not to have to get up here and speak. Well, like she said, we had our phone interview. I think it's been, was it last week? Yeah. You know, you build up for it and you build up, and when it finally gets here, it's like, it's over. You know, it's just like everything else in life. I guess you're nervous about it. And it was grueling because I felt like I was going to vomit, like the minute they scheduled it. So, you know, it was like a week or 2 of, oh my gosh, can we do this? We took Anne's advice as far as not putting too many people in the room. We had myself, project lead, my unit manager, Mary, and then we had the prenatal clinic. And she's not the supervisor, but she's the one that kind of knows how things roll in the clinic. And I was trying to think of specifics as far as what they...
Anything that surprised you?
Well, they asked about formula feeding, which I knew that was coming. What formula feeding education do you provide in the prenatal clinic? None. You're supposed to say none, and I knew that. Then they turned around like 2 questions later and said, so tell me a little bit about the education on formula feeding in the clinic. Did we just answer that? I mean, it was like, we don't do any formula feeding. She goes, perfect. I mean, that's what they want to hear. She did ask about, apparently, now we kept all of our certificates for everyone who had finished training. We copied those certificates and we filed them away for physicians and for our staff. They wanted to know how we kept track of that, because apparently a lot of hospitals, the physicians are finishing their training, but they're not sending a copy to the person to keep that on file. So that's one thing she said, you know, after I told her we had everyone's certificate, she said, well, that's good because a lot of facilities are not. So one way that I guess places are getting away with that is getting a paper signed by the physicians saying that they finished their training. So I don't think that's enough. I think I want a piece of paper to say, yes, we finished this training, but that's one way to cover it. They wanted to know about our policy. Now, we have a system at our hospital that's called Policy Tech, which everything comes out through the internet. You know, you have a new policy to review, but there wasn't a way to just print off our physicians and staff's review of that policy. So I went around manually and had people sign. Here's the policy, review it, sign here. And it was so funny because I really thought they would want to sit there and go through it and ask questions. And they're like, where? Just, you know, sign it. It's like, okay, I've covered myself, so I'm good with that. But I do make sure I tell them, you need to be aware of where the policy is, what it states, because they're going to ask you these questions. The other thing is just making sure that you start this process and you think you've got everybody educated, but like we kind of run into, we've lost our momentum. And so now we're kind of to the point where we're to the final destination and we're having to remind people, are you sure you're teaching the right way? Do you remember how to do manual expression? I know you're teaching it, but are you doing it the right way? Just updating your staff to make sure that things are going the way it should be going. Let me see what a couple. Yeah. Oh, I'm good. Thanks. I'm perfect. I know you're having 2 minutes because Becky's got the commission's here. Cammy's just going to finish it off, okay?
Yeah. Hello again. So we were out at Chickasaw on Wednesday, and it was my first time doing a mock interview, so I'm kind of learning all of this. I'm an LC, I'm a frontlines person, so doing this kind of admin stuff is very new. I would say the one thing, for me, I was very much there to learn, and that tends to be how I come into environments anyways. I kind of just sit back and I walk a little behind the group and I observe and take things in. But I'd say especially for the mock interview, the one thing that I noticed, which is what I wanted to learn more about and get more practice doing, is to be prepared for pushback. I mean, if your pediatrician answers, is pushing back. I mean, for us at Chickasaw, it was around doing the exam in the nursery, and they didn't want to take the baby, do that in the room, and Anne's going to call you on that. And it's not, and I would imagine when BFHI comes, they just don't have time to do that. I mean, you fail, right? So then it's done. So that would be something that I would say maybe not everyone's prepared for is that you got to be ready to be able to say why you're doing things, and if you're not, it's not necessarily going to be pretty and be like, oh, that's nice, So yeah, that's the one thing I learned, which is definitely an area that I want to get better at. But it was really great to see. It was really nice. I spent a lot of time in hospitals, and it was really neat to kind of walk through it with a different lens. I was kind of walking through these hospitals in a new way. So yeah.
Okay, so I don't think we have time for questions, right, Becky, because we want to move on to the next thing. So thank you all very much. No, it's okay. It's okay. Thank you all very much. Okay.